Hi, I'm Jackie,
And I'm Taylor.
and we're in our pharmacology class discussing our case study number 3.
So we're gonna just talk about the meds and you're not there.
All right, so we have Miss T. She's 84 years old. She comes to us from falling at home. There are no injuries from the fall that were observed. The patient also has not been eating very well, so we got to keep that in mind. Some of the levels that I found was that the creatine levels are high at 1.5. All of her vital signs seemed good, and we found that the LDL levels are elevated at 167.
Okay.
A couple of the meds that we found was Atenol, which is a beta blocker. The side effects are that dizziness and fatigue comes along with that. It increases the creatine levels, which we found here is that they were elevated at 167. Atenol, and we found that the contradicted Atenol and furosemide together, and which is the next medication that we have, which furosemide is a diuretic, and some of these side effects are vertigo, headache, dizziness, weakness, blurred vision. So now that we kind of know that furosemide and Atenol are contradicted together,
Yeah.
I mean, it would probably be a good idea to mention.
Should we maybe take her off the Atenol?
Yeah, try to mention it to the physician that they're contradicted together. With the furosemide, we'd like to, monitor the electrolytes closely. There also is a orthostatic hypertension risk, and so we want to monitor the blood pressure closely. And also with the furosemide, there's an ibuprofen interaction, which increases the effectiveness of the diuretic. So,
Okay. And then we would taper her off the Atenol.
yep. And because Atenol is it needs to be tapered off. So,
Okay. Okay, so then I see she's on lisinopril, an ACE inhibitor, getting 40 milligrams. Dizziness, headache, fatigue. Maybe that'll play a risk in her fall.
yeah.
Also, orthostatic hypertension. Looks like her ortho vitals were pretty good though, so that's good. We'll keep monitoring her blood pressure. This also increases the creatine, so we'll definitely have to monitor that too.
Yeah, now we kind of have 2 medications.
Increasing the creatine.
Yeah.
This one works good with beta blocker and aspirin, but we're probably gonna taper her off the Atenol.
Yeah.
And then she's also on glyburide, which is on the Beers criteria, getting 5 milligrams by mouth. This is an anti-diabetic, so we probably want her on that if she's going to be type 2 diabetes. Some side effects are blurred vision, nausea, heartburn, and increased cholesterol, which is a little concerning since we said her LDL was at 167.
Yeah, so that could play a role in that increased level.
And then the pantoprazole is an anti-ulcer med for GERD. So we probably keep her on that one. I kind of like that med.
Yeah.
Side effects are dizziness and headache. This one's not really contradicting to any med, so
no,
maybe we should keep her on that one.
Yeah.
It says it has side effects with aspirin, which she's also getting. So maybe we'll monitor to make sure she's not having any side effects with that.
Yeah. Oh, and then looks like she's on aspirin 81 milligrams daily. Looks like this also increases the creatine levels. This one says that they're also, along with the furosemide, this one has an ibuprofen interaction as well. It says to take drug with food, which is kind of concerning because she doesn't really have an appetite, so we would really want to make sure.
That'd be good for her GERD too.
Yeah.
Okay.
And then this one also causes confusion and dizziness, so kind of seeing that they all kind of have
same side effects.
Side effects like dizziness, we really want to make sure she's on a high risk falls.
Okay.
And then she's also on ibuprofen, which they contradicts with
a lot of
things,
okay.
also with the aspirin. So I think that we should discuss with a physician about the ibuprofen. Although that the ibuprofen is take when needed, I feel like the aspirin gets along better with her medication. So
yeah, definitely. Okay. And lastly, it looks like she's on Megastrol, which is also on the Beers criteria. This one, it says she was recently put on for weight gain, but she's weighing 167. She does have a low appetite, but we could probably do different interactions to help that, couldn't we? So it says Megastrol is appetite stimulating is unknown, so that's kind of concerning if it's to stimulate appetite.
Especially with some of beers,
Yes. And she's 84 years old, so maybe we could talk to the physician about this med as well.
Yeah.
It looks like it increases her blood sugar, which she's a diabetic patient, so it's probably not great.
Yeah.
And you can't just put this patient on this med for weight loss if they're not even doing anything to help themselves already for losing weight.
Yeah.
So maybe we could take her off the Megastrol.
Yeah, I think that'd be a good idea.
So because we did case study 3, we're going to talk about why we thought she fell.
And we think this is because all of her medications kind of cause a dizziness, headache, vertigo. So we would put her at a high risk for falls.
And she's not having a big appetite, so that's huge if you're a diabetic, low blood sugar, you're not eating, you're making it worse for yourself. So
also the meds, she's also has polypharmacy. She's taking many meds. So we just want to keep that in mind. Because she's not eating, and because she's a diabetic, it's probably a lot has to do with low blood sugar. So we just want to be aware of that and make sure that she's eating right, even, to raise it a little bit, just maybe a hard candy or orange juice.
Or supplements, promote eating, promote drinking every time you're near the patient.
Yeah.
So the medications we would like to see changed, like added or dropped, would be the Megastrol we would like to drop. Probably the ibuprofen I think we went with because there were so many contradictions.
Mm-hmm.
And the Atenol, we would like to taper that dose. But we'd obviously call the physician and see what he thinks about this and see if we could get her on less meds.
So we feel like we could use this for our personal practice just because we do work with elderlies in the hospital or hospital setting, and we do see a lot of polypharmacy, and I mean, no one has, really goes through everyone's med list, kind of take out the things that could be making things worse and like hurting them. So
we would just like to see it more done in the hospital, and this kind of makes us more aware of that.
Yeah.
Like, we see report getting done, but do we see people actually taking, like everybody, do we see everyone taking the time to do this? No, I don't. So this is important because we can, being on the other side of it, seeing like what's being done and like the, I don't know, underneath it all, we can kind of promote it more, I feel like, being new nursing students and when we get out on the job.
Yeah.
Really like take the time. And this will help us for clinicals.
Yeah, definitely. And how this applies to our knowledge, it just, it's training us and helping us to, understand the meds more and just what we want to find, what, the meds we want to look at, what their vitals look like, what their levels look like. It's just...
It definitely helped us investigate more than we were on the DocuCares, I think. And take the time and realize what was actually going on beneath it all.
So we thought this was a really good project and it was fun to do. So thanks for listening.
Thank you.